It's really a great pleasure to welcome virtually Dr. Ciaran Kelly from Beth Israel Deaconess Medical Center and Harvard Medical School. Ciaran, it's great to see you and wish you were here, but let me just introduce you. So Dr. Kelly trained in his native Ireland, Trinity College, Dublin University, got his MD there, and did his internal medicine and GI training at the Federated Dublin Hospitals, as well as pulmonary and GI training at St. James Hospital, all in Ireland. And then in 1989, moved to Boston University and was an assistant professor initially at Boston University Medical Center, rose to associate professor. And then when Tom Lamont moved from Boston University to Beth Israel Deaconess to be the chief, Ciaran also left and joined the Harvard Medical School faculty, where he has risen through the ranks to professor of medicine. In 2004, he founded and continues to direct their Celiac Center. He's also the program director for their fellowship for many, many years. He's been an associate editor for Gastroenterology and is editor-in-chief for Current Opinion in Gastroenterology. And he has numerous publications approaching 300 or so, mostly original papers, but many reviews, chapters, and editorials, covering a wide range of topics, but most especially C. difficile and celiac disease. He's a world-renowned speaker, lecturer, educator, and it's really such a pleasure to see you, although we wish you could be here in New York City and take you out to dinner. So you'll have to take a waiver on that, and we'll have you back another time, Ciaran. Thanks for joining us.
Yeah. Thank you for your kind introduction, Bruce. Yes, I remember that, going out for dinner. I remember when I did that. Haven't done it in a while, unfortunately.
Yeah, exactly.
Thanks for accepting demotion to Chief Fellow on my behalf, Bruce. You didn't mention when I was recruited to Harvard from BU. I was actually demoted from associate to assistant.
I was not going to mention that at all. And I also was not going to mention that I was a medical student when you were an assistant professor at BU.
Yeah, I happily accepted the demotion. It was a good career move. If it didn't please my mother that I was no longer associate professor, we overcame the hurdles, and yes, indeed, most of my work has been on celiac disease and Clostridium difficile. And my lab meeting, my weekly lab meeting, we call it the Tale of the Two CDs, with apologies to the Tale of Two Cities, a terrible pun, but we find it amusing. So shall I begin? Sorry, as I just tried to bring this up to full screen. There we go. Good. So it's a great pleasure to talk about one of my two favorite topics, and that is celiac disease. Sorry, it doesn't seem to want to move along for me. With your system, can I use my forward buttons on the laptop, or do I need to use a button on?
There should be a little button in the lower left-hand corner of your where your slide is, I think.
You move the mouse to the lower left, a little set of arrows may pop up.
Yeah.
Or not.
Or not. I did move the bar, so maybe that's why I jinxed it. Ah, yes.
Yeah.
Yes.
Now once you do that,
They're hard to see.
But once you do it once,
they're virtually invisible, but I can see them now.
but once you do it once, you should be able to use your keyboard or your mouse or whatever you want.
Great. Okay. Well, that worked. Thank you. So when I came to Boston from Boston from Ireland, I met with my chief, Tom Lamont, who many of you will know. And Tom asked me what I wanted to do in Boston in terms of research. And I said I wanted to do research in celiac disease. And Tom said, I'm sorry, Ciaran, but there isn't much celiac disease in Boston. You're going to have to do something else. And what he said was not entirely wrong, because at the time, the accepted prevalence of celiac disease in the US was in the order of 1 in 5,000. But that has changed dramatically. And with those changes, there is now an acceptance of a prevalence of celiac disease in Boston and the US of approximately 1%. Most of these patients being undiagnosed, many, but not all of them being symptomless or silent celiac disease. And one of the big reasons for this increase in the numbers of patients that are being diagnosed with celiac disease is the introduction of a very powerful serologic test for celiac disease, which is IgA tissue transglutaminase. And this was introduced by my colleague Detlef Schuppan, who worked with us at the Celiac Center in Boston for several years, now has returned to Germany. But this test allows an individual, usually a primary care physician, to very quickly evaluate a patient for possible celiac disease and either make a probable diagnosis if the TTG is positive, or exclude the disease with reasonable certainty if the TTG is negative. So that has been a big step forward in diagnosis. That same serologic approach has also been very valuable in epidemiologic studies of celiac disease. And I'm showing here the result, summary of a meta-analysis that we performed regarding the prevalence of celiac disease in different parts of the world. And you can see that in in Europe, the prevalence is a little over 1% by serology and 0.8 by histology. So this difference in prevalence between histology and serology is not so much that serology is more sensitive or has more false positives. It's in fact the fact that many studies where serology is employed, not everyone has a biopsy. And so there is not histology available for everyone. And in this study, if a patient did not have histology, we assume that the histology was negative, which is why you see the discrepant results throughout. So whether you're in Europe or North America, South America, or Australia, there's very, very similar prevalences serologically and histologically of celiac disease. The prevalence in Africa overall, based on the literature, is very similar, but most of this literature comes from North Africa, and the prevalence of celiac disease in sub-Saharan Africa appears to be lower, although it has not been extensively studied. And similarly, there's a difference in Asia. Most of the studies from Asia have come from India, where there definitely is a high prevalence of celiac disease. And in fact, parts of India appear to have the highest prevalence of any of the regions that I've highlighted. But there are other parts of Asia where the prevalence seems to be lower, for example, China and Japan. And this often reflects the prevalence of the celiac-associated alleles, the DQ2, DQ8 alleles. But overall, it's easy to remember, it's about 1% wherever you look. And so why this big increase? Well, I've already pointed to the availability of TTG serologies, but there's probably at least one more reason. This is a study from the Mayo Clinic by Joe Murray and his colleagues, and they were able to access a large number of sera from 1950, and they tested these sera for celiac disease. The sera came from young adults at Warren Air Force Base. And in this 1950-ish sample set, they found 0.2% with clearly positive, definitely positive TTG, above twice the upper limit of normal. Then they looked at controls, and they actually looked at two sets of concurrent controls. These were samples gathered around the year 2000. And there were two groups of controls, both quite large groups. One had a similar year of birth to the Warren Air Force Base cohort. And the second control had a similar age of sampling, so in their early 20s at the time they were tested. And both of those control cohorts had 0.9% prevalence of celiac disease. So that would suggest that there may be a real increase in the prevalence of celiac disease between those two time periods. Interestingly, those who tested positive on their 1950 sera were 4 times more likely to have died during the interval time compared to those who tested negative. And so there's some association between being TTG positive and increased risk of death. It may not be celiac disease, but being TTG positive may mark, for example, a certain immune cohort who are more susceptible to other disorders. But one way or another, there was an increased mortality rate. Take-home celiac disease is 4 times more common now than it was 50 years ago. And having a positive TTG is associated with an increased risk of mortality. So a question, what's the average age of diagnosis of patients with celiac disease in the US? Is it 5, 15, give or take 25, around 35, or an average 45? Well, since we don't have a to and fro, I'll take you out of your agonies and tell you that the average age of diagnosis is 45 years, and that's true across the US, and it's certainly true in our practice. So it's not a pediatric diagnosis. It's individuals in adult life are when they're most likely to be diagnosed. Whether they've had celiac disease all their lives, from age 2 years all the way up or not, is unclear, but the diagnosis is occurring largely for people in their 40s. And so who? Well, I showed you it's common to many ethnic backgrounds and geographic regions. The age of diagnosis is not in children anymore, but in adults. And the presentations are highly diverse. And perhaps because of the very diverse presentations, diagnosis is often delayed. I mentioned earlier that only a fraction of those with celiac disease in the US actually are diagnosed. One of the reasons for this is that the symptoms may be minimal or subtle. Another reason is that they are very diverse and patients do not present with classic symptoms of malabsorption, and so the diagnosis may be missed. This is a listing of common and less common features of celiac disease, associated conditions such as dermatitis herpetiformis, IgA deficiency, and complications such as enteropathy-associated T-cell lymphoma. And I don't expect you to read down and memorize all of these. The point of the slide is that the manifestations are very diverse. And really, the disorder can present to any medical specialty. My professor at Trinity, where I started to learn about celiac disease, would, when he was lecturing the medical students on celiac disease, would say, I'm going to give you a very important lecture now, and I want everyone to listen. And it doesn't matter whether you're going to become a pediatrician or a neurologist, an endocrinologist or a gastroenterologist, or God help us, even if you become an orthopedic surgeon, you will all have the opportunity to diagnose celiac disease. He did not like orthopedic surgeons, as you might have guessed, but included them as physicians who can diagnose celiac disease depending on the clinical presentation. So I already mentioned the most powerful serologic test, but just a few words on the other antibody tests for celiac disease, in case there's some confusion about their place in clinical practice and diagnosis. The anti-Gluten antibodies, IgA and IgG, were the first serologic tests available for celiac disease diagnosis, but they have been superseded. And the reason their weakness is a very low positive predictive value, a very low specificity. Their sensitivity is reasonable, but they have a low specificity. And so a lot of individuals will be positive on anti-Gluten antibody testing who do not have celiac disease. And certainly I've done many, many small bowel biopsies on patients because of a positive anti-Gluten antibody yielding a normal small bowel biopsy. So the more accurate endomysial antibody, which is an immunofluorescence test, It's an excellent assay, but it's a bit more difficult to have it done and more difficult to interpret. Requires an expert immunofluorescence reader, a person to read the immunofluorescence result. And the TTG, which is the go-to test that most of us use on a daily basis, which is an enzyme immunoassay. So it's automated and relatively straightforward, simple, and inexpensive to obtain. And so the positive predictive values with the EMA and TTG are much higher than the old anti-Gluten antibodies. Of course, they're not perfect, but they are very, very good. Their sensitivity is superb. The only other one of the list that I've shown up there that I'd like you to make you aware of is the IgG anti-deamidated gliadin peptide antibody. And so this is a clever use of a knowledge of celiac disease. Gliadin positions itself on the HLA-DQ2 molecule to be presented to the T cell receptor. However, if gliadin peptides are modified by tissue transglutaminase, the deamidated peptides position themselves much more closely and much more tightly on HLA-DQ2 or DQ8. And as a result, they mount a much more potent immune response. And many believe that it's actually deamidated gliadin peptide that largely drives celiac disease rather than the native gliadin peptides. So aware of this phenomenon, workers developed new antibody tests aimed at gliadin. The old traditional tests of the simple anti-gliadin antibody test had a diagnostic accuracy in somewhere in the 70s, whereas the new test using I'm after setting my my forward and back. Let me try again.
It should work if you do what you did before.
Yep. The little icons are not appearing for me. I moved the bar down. I've stopped moving this bar. It's obviously upset with me for doing that. Yes, yes, I moved the bar back, and
Yeah, they're back.
Yes.
It's really hard to see. It's a couple over, yeah. Huge.
Oh dear. All sorts of interesting things are happening now.
So you clicked the one that magnified it?
Probably, because
you did. All the way to the left, a couple to the left. More, that one.
That's it. Good, thank you. You should come here and drive all together. You do a much better job than me.
I'd love to go there. We're not allowed to travel, remember?
That's right, that's right. So as I was saying, the diagnostic accuracy of the DGP is greater. Okay, I'm beginning to learn how this works. By the time the talk is over, I'll have figured it out.
You're a star.
So why do we need another serology tests when IgA TTG is so good? So where I use the IgG DGP, I used to use it a lot when patients were referred to me with a positive anti-Gluten antibody, old IgA or IgG AGA, and a negative TTG. And I would assume that they did not have celiac disease, but I wanted to discredit their anti-Gluten antibody test. And so I would do a deamidated gliadin peptide that would be negative, and I would be confident that they did not have celiac disease. Another situation where I use it is where a patient has a positive TTG, but for some reason, a biopsy is not possible or acceptable. One example was a ICU nurse who was pregnant in her mid-trimester and developed diarrhea and weight loss and tested positive for TTG. And she did not want to undergo an endoscopy during pregnancy. So having a positive DGP was reassuring in terms of the likelihood that a diagnosis of celiac disease was indeed correct. She also responded beautifully to a gluten-free diet, which supported the diagnosis. And ultimately, after her pregnancy ended, she decided that she was happy with the diagnosis and would not undergo a gluten challenge and biopsy. And then the final situation where I use it is in patients with IgA deficiency, because the IgG-DGP is almost as sensitive and specific as TTG. And it certainly is more diagnostically accurate than either an IgG-TTG or an IgG-EMA. And so it's the preferred IgG-based test for patients with IgA deficiency. So a case. 68-year-old man is diagnosed as having celiac disease 14 months ago after he presented with diarrhea and weight loss. Duodenal biopsies showed partial villous atrophy and an increase in IELs. His serum IgA antiglidin was positive, but serum IgA-TTG was negative. His total IgA was normal. He did not respond clinically to a gluten-free diet. With that scenario, which of the following diagnostic tests would you recommend doing next? Would you do a repeat antiglidin antibody? Would you do gene testing for DQ2, DQ8? Would you repeat the small bowel biopsies to evaluate healing on the gluten-free diet? Or would you do a hydrogen breath test for bacterial overgrowth? Well, again, since we don't have a back and forth, I will tell you that I would recommend doing gene testing. Clearly, this patient has an atypical presentation in terms of diagnostic findings, in that the TTG is negative despite villous atrophy. The positive antiglidin antibody is neither here nor there, because we know that that test yields a lot of false positives. So repeating the antiglidin antibody will still not be reliable. Repeating the biopsy will probably show that he still has villous atrophy, since he has ongoing symptom. The breath test for bacterial overgrowth is a reasonable thought, but it's unusual for bacterial overgrowth to present predominantly in this way, or to have clear villous atrophy. Usually the histologic findings in bacterial overgrowth are subtle. And so the next best approach here is gene testing, because a negative gene test for DQ2 and DQ8 will exclude celiac disease and tell you that this patient has non-celiac villous atrophy. So DQ2 and DQ8 are common in the general population. And in fact, about 40%, give or take, of the general population will be positive. And so the test has a very low positive predictive value rather, for diagnosis of celiac disease. Its strength is in its negative predictive value, because essentially everyone, greater than 99% of patients with celiac disease, will be DQ2 or DQ8. And so if it's negative, basically you can essentially, there are always exceptions. And in my practice, I've come across 3 patients who are DQ2, DQ8 negative, who I'm convinced have regular celiac disease, but it's very, very unusual. The reasons for testing, as I said, it's because it has a high negative predictive value. It's also not altered by the gluten-free diet, and we'll come back to that point later. And one of the main reasons for genetic testing is where there's equivocal histology and serology, where they disagree. So we've been talking about diagnosing celiac disease. A few words on common errors in diagnosis. One is a clinical response to the gluten-free diet. I'll talk about that a little more later, but it is not a reliable diagnostic factor. Antiglidin antibodies are already debunked as being non-specific. If you come across a patient who has fecal antiglidin antibodies, usually they come with a printout of their results in hand, and nobody can interpret them because they haven't been evaluated or validated. They also have paid several $100s for the useless result. I do see patients who, because they have symptoms consistent with celiac disease, show some improvement, usually partial, but nonetheless some improvement on a gluten-free diet, and are HLA-DQ2, DQ8 positive. It's considered that that grouping of signs and symptoms is sufficient for diagnosis. It is not, because none of those findings are specific for celiac disease. You either need celiac-specific serology or you need villous atrophy on biopsy. And then finally, and this is not all that unusual, is that there's a mistake, an error in the interpretation of the biopsy, either false positive or false negative. And so if things are not adding up, it's always worthwhile getting a good GI pathologist to review the diagnostic histology to see if it is truly consistent with celiac disease. So this is what we see endoscopically in a patient with fairly severe untreated celiac disease. The features are loss of folds, a mosaic pattern, nodularity, and scalloping. And those features are reasonably specific if they're found, but they're not especially sensitive. And so I always say, if you see any of those features, you should take biopsies because it is probably celiac disease. If you do not see any of those features, you should take biopsies because it could still well be celiac disease because the sensitivity of those features are low. And I think everyone at this point knows that it's a patchy disease, non-uniform, and so the recommendation is to take multiple biopsies from the second or third parts of the duodenum. Whether or not to also take a duodenal bulb biopsy is still a little bit controversial. There are studies showing that it may increase sensitivity for celiac disease diagnosis, but also at least one study suggesting that it may reduce specificity for biopsy. And so I tend to take bulb biopsies where I have a relatively high clinical suspicion for celiac disease, but otherwise not. But that's just my practice. Some years back, and it has since ebbed, but some years back, overnight almost, we were getting a myriad of histology reports of increased intraepithelial lymphocytes. And to make things worse, the reports read increase in intraepithelial lymphocytes consistent with celiac disease, or consistent with early celiac disease, or consistent with mild celiac disease. But in fact, an increase in intraepithelial lymphocytes, although it is an early feature of celiac disease, is also a feature of a multitude of other disorders. And there's a long list of conditions where intraepithelial lymphocytes are increased. And so I consider it a non-specific finding. And if a patient has an increased IELs on small bowel biopsy, I will do a TTG, and if I will allow the TTG to adjudicate whether or not the increased TTG needs to be evaluated further vis-a-vis celiac disease. So I already spoke a little bit about disagreements between the two tests. These are situations where the TTG may be positive, but the biopsy normal. Was the TTG assay used a good assay? Was the biopsy really normal? Again, has an expert GI pathologist evaluated the biopsy? Some patients, when they hear vague rumors of celiac disease from their friends and family, will go on a low or gluten-free diet even before they see the physician get testing and get biopsy. And of course, that can affect the results of the biopsy. And then finally, as I already mentioned, the disease, or not quite finally, but as I already mentioned, the disease may be patchy, and so it can be missed. There is, however, a phenomenon of patients who have positive celiac-specific serologies and normal histology. And these patients are said to have potential celiac disease. I consider them to be on the spectrum of celiac disease. Usually they have risk factors. For example, they are a family member of somebody with celiac disease, or they have type 1 diabetes mellitus. And the natural history of this disorder is that if they have symptoms consistent with celiac disease and potential celiac disease, they will often benefit from the gluten-free diet. But if they do not have symptoms, then usually they will continue with potential disease and not develop overt disease. And so basically the decision as to whether or not to start a gluten-free diet in these individuals is based on whether or not they're symptomatic. The opposite then would be where the TTG is negative and the biopsy is not normal. And here you have to look for IgA deficiency. It's good as a backup, as I mentioned, to use IgG-DGP, to consider non-celiac enteropathy. And this is a situation where gene testing is valuable. And yet again, as always, an expert review of the histology. So here are two biopsy photomicrographs. On the left, normal villi, on the right, villous atrophy. Which of these can't eat gluten? And the answer is neither can. And that is because the patient on the right has so-called non-celiac gluten sensitivity. It goes by other names, but basically there's an intolerance to gluten without there being celiac disease. And so this is a landmark study in this disorder, which did a randomized, double-blind, controlled, placebo-controlled trial, looking at patients where a diagnosis of celiac disease had been confidently excluded and challenging them blindly with gluten or placebo. It should really be nocebo, because you're not looking for a pleasing response, you're looking for a negative response. So it's a nocebo response. And you can see that the individuals who received the so-called placebo did indeed have some increase in their symptoms, but it was less than those who received actual gluten. So this would suggest that the phenomenon of gluten sensitivity may be a real phenomenon, since it showed itself in this randomized trial. This is a survey study that was done by the group at Mayo Clinic, looking at use of the gluten-free diet. And what they found was that there were about, extrapolating the results of their study, there were approximately 2 million people in the US on a gluten-free diet. Coincidentally, there are also approximately 2 million in the US with celiac disease based on the seroprevalence at that time. But there are only a small number who are both on a gluten-free diet and have celiac disease. So most people with celiac disease are not on a gluten-free diet, and most people on a gluten-free diet do not have celiac disease. So I hope you don't find that at all confusing. Another case. This is a 46-year-old woman who reported abdominal pain and bloating and was diagnosed as IBS. She has not lost weight and does not have diarrhea. She started a self-prescribed gluten-free diet 9 months ago with substantial improvement in her symptoms. Her blood work is all normal, and she comes to you asking, does she have celiac disease? Which of these tests would you consider the most important first test? Symptom response to gluten ingestion, in other words, a gluten challenge. Endomysial antibody, test of regular symptom response or a form of gluten challenge. Those are two separate options, Endomysial antibody, genetic testing, or deamidated gliadin peptide. Well, here again, I think that the recommendation in evaluating patients who carry a diagnosis of celiac disease but have not had adequate testing prior to the diagnosis, that the first step prior to considering a gluten challenge, I'm assuming here that the patient is TTG negative, And if you check DGP, that would also be negative. So assuming a negative TTG, then the next test that's recommended is gene testing, because if the gene test is negative, and in our practice, almost half of these patients will have a negative DQ2, DQ8, about 60% are negative, sorry, 40% are negative on DQ2, DQ8. And that obviates the need to consider additional diagnostic studies such as a gluten challenge. So these dudes are driving along the coast, possibly the West Coast, but I'm not sure. And one says to the other, I've no idea what gluten is either, but I'm avoiding it just to be safe. And this sort of reflects what is now a commonly recognized phenomenon of gluten sensitivity or gluten intolerance. So this is some pros for people with celiac disease, because there's more awareness of gluten as an entity, probably easier access to gluten-free foods, and possibly, although I don't think it's likely, lower cost gluten-free foods. But there are cons as well. And the main con that patients with celiac disease report is that they're not taken seriously when they're eating out in restaurants, when we used to eat out in restaurants. And one of my, because they're seeing individuals come, ask for the gluten-free diet menu, order from the gluten-free menu, and then have apple pie and ice cream for dessert from the regular menu without batting an eyelid. And so that gives mixed messages to the wait staff and the kitchen. One of my patients told me that when she went to a restaurant recently and asked for the gluten-free menu, she was asked by the wait staff if she had biopsy proven celiac disease. So it's getting to the point where people are going to have to bring their celiac license with them in order to get a truly gluten-free food. So if you have these patients with who are not diagnosed but on a gluten-free diet, here are some indicators that you may find helpful in terms of having celiac disease. If they have typical celiac symptoms, if they have a family history of celiac disease, or if they have evidence of any nutritional deficiency state, that increases the likelihood that you will discover that they do indeed have celiac disease, and vice versa. TTG is very valuable. Here you're asking, was the TTG ever positive? The first time they went to their primary care doctor 5 years ago and celiac disease came up as a question, did their doctor do a TTG and what was the result? Because that going back to a TTG, particularly before the gluten-free diet, is exceedingly valuable. Similarly, if they have a negative TTG on a regular diet, that's also helpful in terms of excluding the disease. So the typical regimen, so assuming that an individual with unproven celiac disease on a gluten-free diet is TTG negative and HLA DQ2, DQ8 positive, the next classical step is a gluten challenge. I've tried to start calling it a gluten-free diet holiday rather than using the negative term, a gluten challenge. Some patients take to this kindly and most are not at all fooled. And so what we're looking for here is a deterioration in villous height and an expansion of crypt depth. And Dan Leffler and our group looked at this in individuals with celiac disease and performed a gluten challenge. And you can see that over the course of a 2-week gluten challenge, we found significant fall in villous height to crypt depth ratio. Interestingly, we did not see serologic response during the gluten challenge, and we only saw a serology response after the gluten challenge had ended. And so it's a bit like a convalescent antibody response to an infection. You don't see it for some time. And it was 4 weeks before we saw a serology response to the gluten challenge, as opposed to seeing a symptom response within a few days and histologic response within 2 weeks. So the ACG has taken this information to heart and recommends first looking for serology. That was performed before the patient started a gluten-free diet as being very valuable. To do a genetic test before doing a gluten challenge. That it's possible to use lower doses of gluten. I didn't emphasize that, but on the slides I showed you, 3 grams versus 10 grams of gluten had a similar response. So 1 slice of bread is a little over 2 grams of gluten. So you're talking about 1.5 slices of bread versus 4 to 6 slices, which would be the traditional gluten challenge. And then finally, the option for the patient to stop the gluten challenge after 2 weeks if they wish, but if they can persist and continue for an additional 6 weeks, that's the ideal. And in fact, I find that patients are very generally reassured by the option of stopping at 2 weeks, but usually decide not to stop, but to continue, because generally the symptoms that they're experiencing are not as bad as they had anticipated. And then finally, to do serology, but to wait until after the gluten challenge has ended before doing serology to increase its sensitivity. So most patients with celiac disease will show clinical, histologic, and serologic response to the gluten-free diet, but not all do. And this condition is called non-responsive celiac disease. It's quite common. In our series, it was 10% of our celiac patients. And the reasons for this are the patient may not have celiac disease, and therefore a response to a gluten-free diet cannot be expected. They may not really be on a gluten-free diet. They may be ingesting gluten either on purpose or accidentally. They may indeed have celiac disease and be on a gluten-free diet, and their celiac disease may be controlled, but they may have a second diagnosis. And finally, the condition, the disease, may no longer be gluten sensitive. It may be on autopilot. That is to say, they may have refractory celiac disease. So these are examples of patients that we saw who had non-celiac villous atrophy. And all of these patients were referred for 77%, 23 of 30 were referred for evaluation of non-responsive celiac disease, and indeed they did not have celiac disease. Their TTG was negative, and many of them were HLA-DQ2, DQ8 negative. This is a survey study of asking patients about response about gluten in their diet, and patients were asked if they had an inkling of gluten being in their diet, and 70% of patients had an inkling of there being gluten, either known gluten or inadvertent gluten, and only 30 held that there was no gluten in their diet. So most patients believe that they're having exposures to gluten on the gluten-free diet. We actually studied this. I won't go into details, but we called it the doggy bag study because we asked patients with celiac disease on a gluten-free diet to give us a doggy bag following all of their meals, containing 25% of the food that was on their plate. And then we measured gluten in the doggy bag material. And we found that 2/3 had at least one positive sample, and this was just over a 10-day period. And so this closely mirrors the result of the survey study that I just showed you, where 2/3 of individuals on a gluten-free diet have gluten exposures. I just move through this for the sake of time. I'd like to leave some time for questioning. So not just celiac disease, these are the conditions that occur in patients with non-responsive celiac disease. And you can see the most common reason for failure of response is ongoing gluten ingestion. But there are some other quite common causes, including irritable bowel syndrome. Refractory Sprue accounted for about 10% of these patients. So about 10% of patients have non-responsive celiac disease, and about 10% of those, so that's 1% of all celiac patients, have refractory Sprue. Those are the second diagnoses, and then going on to refractory celiac disease, which affects 1 to 2% of patients with celiac disease. It's a condition where there's ongoing villous atrophy with malabsorption despite a gluten-free diet. Studies published in The Lancet showed from the French group of Celiac, showed that there were abnormal cells in these patients with refractory celiac disease. In particular, that in the severe form of refractory celiac disease, patients had CD8 negative, CD4 negative, IL-2 receptor negative. So they had intraepithelial lymphocytes that lacked these maturity markers. And these aberrant lymphocytes are believed to drive refractory celiac disease, and in some instances to transform into T-cell lymphomatous cells. So we don't have great treatment options for refractory celiac disease. Sorry, this is just showing the natural history of refractory celiac disease, and the type 2 form with aberrant T cells has a high mortality rate, whereas the type 1 form does not. Treatment-wise, our go-to agent for non-responsive celiac disease is budesonide, enteric-coated budesonide. We also sometimes use the other agents listed. And just to point out, the clinical guidelines give nice algorithms for the approach to non-responsive celiac disease, pretty much reiterating what I've just outlined. So to summarize, celiac disease is increasingly common. Non-celiac gluten sensitivity may be more common than celiac disease. Non-responsive celiac disease is also common, has multiple etiologies, the most common being gluten exposure. Refractory celiac disease is thankfully rare. There are 2 types, and the type 2 is the severe, more aggressive type that is associated with high mortality rates. And I'll stop there.
Thank you so much. That was great, full of very useful pearls. But now I'm going to ask a useless question.
Oh, good.
Which is, at the beginning, you showed pretty clear evidence of an actual rise in the incidence of celiac over the last 5 to 7 decades.
Yeah.
And this is an impossible question, really, but what is the speculation about why that is actually happening?
So it's not peculiar, because similar increases have been found in other T-cell mediated and other immune mediated disorders, rheumatoid arthritis, multiple sclerosis, asthma, etc. So the favored theory is the hygiene theory. And my mother used to say that an idle mind is a devil's plaything, when she'd see me doing nothing and she'd send me off to do some errand or other. And so the thinking is that an idle immune system is the devil's plaything, and that if the immune system doesn't have worms and the like to attack, it just becomes mischievous and starts developing autoimmunity or immunity to environmental antigens. So that's the theory. Obviously, that's impossible to prove, although there have been some attempts at purposely infecting individuals with, for example, worms, to try to reverse an immune disorder.
Is there any thinking along the hypothesis of just that the intestinal barrier function has been altered by what patients colloquially call, and may be actually true, a pro-inflammatory diet, allowing more exposure?
Well, there's no doubt that individuals with celiac disease have increased intestinal permeability, but beyond that, relatives of people with celiac disease have increased intestinal permeability also. And the same holds true, I believe, in inflammatory bowel disease. So it may well be that might be sort of a basic defect that leads to immune activation. That's definitely a possibility. I'm not quite sure what we can do to improve or reduce our intestinal permeability. I have had patients come with various diets and lotions and potions that are supposed to do that, but I don't think there's any data to support it, to support any of them.
But a rich
and my last useless question before other people ask useful questions is, what are the general medical therapeutic approaches that are in the pipeline?
Yeah, I actually
that you find promising?
Yeah, I had some slides on that, but I was too loquacious and hadn't left time for that. But there are a myriad of approaches. 10 years ago, there were essentially no clinical drugs being developed for celiac disease. Now, there are at least 25, if not 30, that are in active clinical development. So it has exploded as a therapeutic target. For me, the most exciting are drugs that seek to restore or build tolerance to gluten. And some creative approaches are being taken to try to tolerize patients with celiac disease to gluten so that they can safely be exposed to at least small amounts of gluten, if not ultimately to a normal diet.
Thank you. Other questions?
Your question reminds me, however, of on the permeability question. There is in fact an agent that has been shown to improve, reduce permeability, and that's an agent called larazotide acetate, which is being evaluated in a phase 3 study for celiac disease. It's a tight junction modulator.
There was some interest in that in Crohn's disease as well, although it hasn't really progressed.
No, it has not progressed. But there's interest, in a lot of conditions where permeability appears to be a basic flaw.
Yeah.
I have a question. So that was great, by the way. I mean, it's like everything we always needed to know about this, and it's so common. But so I'll ask a question that hopefully, I don't think yours were useless, by the way, but let's talk about usefulness of genetic testing. I mean, sort of a practical guide, because patients come in asking for that all the time, and I know what I tell them, but what's your take on it?
There really are only two clinical circumstances where I find it useful. One is a patient on a gluten-free diet without a diagnosis as a prelude to a gluten challenge. And the second is where there's disagreement between serology and histology, drawing the diagnosis of celiac disease into question. Those are the two situations where I use it. There is a third situation where it's used by pediatricians, and that is to try to exonerate a sibling of having the celiac-associated alleles, so that the sibling of a patient with celiac disease doesn't have to undergo repeated testing. But I would say that 90% of my patients are not tested for DQ8.
Perfect.
Incredible. Any other questions?
Are there risk factors for progressing from like responsive celiac to refractory celiac in for longer periods of not adherence to gluten-free diet or anything like that?
That's a great question, and we looked at it in our cohorts that we've looked at now. We've looked at 2 or 3 cohorts with non-responsive celiac disease, and we were not able to find demographic or clinical features that predicted progression to non-responsive. There are some features that will predict that a patient will not adhere well to the gluten-free diet in terms of personality traits, for example. It may surprise you to know that one of the personality traits that augments likelihood of response to the gluten-free diet is being rebellious. And this surprised us a little. Yeah, when we came across it, you'd think that they would say, I'm not sticking to that diet. But in actual fact, what happens is that these individuals fight their ground when they go into a restaurant, for example, or when they're visiting with their granny and say, no, I can't have any of that food. I have to have my gluten-free food. And so you've got to be a little bit rebellious in order to point yourself out as different in those circumstances.
As someone with celiac, I can attest that that's very helpful to have friends who are rebellious as well, who push back when you're going out to eat together.
Yes. You should assign each visit out. You should assign the rebelliousness behavior to one of your friends in turn.
Thank you.
That's great. Any last questions for Dr. Kelly?
I would just point out that in the chat, you were described as the absolute best by one of the people who was watching. So,
Oh, hey, Dr. Kelly, it's Stephanie. I didn't mean to
that's
tell
a
the
good-
whole group that you were the best, but it's very embarrassing. But thanks very much for the talk.
Hi, Stephanie. How are you?
Nice to see you. I'm great. How are you?
Good.
Thanks a million. That was fantastic.
Ciaran, thank you so very much for joining us this morning. It's been it was a wonderful lecture. We
My
promised
pleasure.
to have you in.
I guess you owe me dinner.
I was going to say I owe you dinner, and I will happily bring you to dinner when that is possible.
Sure. Okay, everyone.
Thank you, everyone.
Thank you for
Thanks so much.
for listening. Bye-bye.